diagnosed persons with MS, a pilot study. As you are likely aware, receiving a diagnosis of multiple sclerosis can be a highly stressful event. MS has an unpredictable course, and the anticipation of future relapses or progression can be stressful. This uncertainty for the future can affect psychological, social, and economic well-being. Previous studies have shown that emotional distress is identified in 90% of persons with MS experiencing relapses, compared to about 40% with stable disease. Additionally, persons with MS frequently develop depression, anxiety, and fatigue, which can further impair their quality of life. Other studies have shown that stressful life events have been related to new brain lesions on MRI. Additionally, negative effects of stress can be physiological and may be mediated by inflammatory or immune markers, which can be important in multiple sclerosis. Associated with better mental health and quality of life reports. Better coping skills was also associated with a reduction in new lesions on MRI, as well as clinical relapses. Mindfulness-based interventions could be a potential approach to improve coping skills in persons with MS. Mindfulness is defined as a meditative practice that involves focusing one's awareness on the present moment while acknowledging and accepting without judgment one's feelings, thoughts, and bodily sensations. Previous studies in other populations have demonstrated a positive effect on anxiety and mood symptoms. Here are our study objectives: to assess whether a mindfulness-based intervention would improve the coping skills and coping abilities of newly diagnosed persons with MS, as well as to look at whether this mindfulness-based intervention would lessen the negative consequences of stress, specifically looking at perceived stress, mood symptoms, and quality of life. Ages 18 to 59, the confirmed diagnosis of relapsing multiple sclerosis within 1 year of the first mindfulness-based intervention session, as well as being fluent in English. Potential subjects were excluded if there was a major psychiatric disease or another disorder that would prevent participation in the intervention. Additionally, if the subject did not feel he or she could attend 80% or more of the mindfulness intervention sessions, they were excluded. During the course of the study, subjects were removed if they experienced a relapse during the course of the intervention or the equivalent time frame for the control group, or if they missed 2 or more sessions. All subjects were assessed at baseline, post-intervention or equivalent time, as well as 6 months later. The primary outcome was the brief COPE measure. Secondary outcomes included measures of anxiety and depression, perceived stress, self-evaluated cognitive function, fatigue, quality of life in the short form 36, as well as the Kentucky Inventory of Mindfulness Skills. Stress in persons with MS, which used the brief COPE as the outcome. The mean score was 63, with a standard deviation of 8.5. We considered a 20% improvement, or approximately 3-point improvement on the brief COPE, to be clinically meaningful. Based on this information, our sample size calculation stated we needed 8 subjects in the intervention and 8 control groups to reject the null hypothesis with a power of 0.8 and a p-value of 0.05. To ensure an adequate sample size, due to the possibility of relapses or other reasons that patients may withdraw, we aim to recruit 26 subjects in total. The statistical analysis was ANCOVA to compare longitudinal changes on the outcome measures with baseline scores employed as covariates. This slide shows the recruitment and randomization. In order to ensure that the mindfulness intervention was administered appropriately, 2 sessions were run such that no more than 10 subjects were in the mindfulness-based intervention. 55 subjects were assessed for the fall intervention and 39 for the spring intervention. Several were excluded for medical reasons or a diagnosis greater than 1 year before the first session, as well as marijuana use. Several subjects declined as either not interested or too busy, and many found it too far to travel to perform in the in-person mindfulness-based intervention sessions. Here you can see that 6 subjects were allocated to the fall intervention group and 10 were allocated to the spring intervention group. Conversely, 3 subjects were assessed in the fall control group, whereas 6 were in the spring control group. Few subjects discontinued or were excluded from the analysis. The final analysis included 25 subjects, 16 in the analysis and 9 in the control group. Mean age of 38.4 years, a predominant female gender with a low EDSS at 2.0. They were on average 5.1 months since diagnosis of relapsing multiple sclerosis. There is no significant differences between those randomized to the intervention group compared to the control group. Demonstrates the statistical difference on the measures after the intervention immediately. You can see here that the brief cope improved in those who went into the intervention group compared to the control group. Similarly, those in the intervention group improved their depressive score, whereas the control group remained relatively stable. Finally, the perceived stress scale decreased significantly in the mindfulness-based intervention group compared to the control group.